I'm João. I'm one of the members of Cochrane's Early Career Professional, and we are starting our pilot series right now. So I'm just gonna give a quick introduction before I leave to Fabio about what we do and what are our main objectives. So let me just present the. Okay. So this is a project that we developed here at Cochrane Early Career Professional. It's the first project of our lecture series. So at first, I would like to address what is the Cochrane Early Career Professionals Network. Cochrane is a global network, nonprofit, independent organization that has with the main objectives of developing high quality research, especially in terms of systematic reviews. It's a reference for uh, healthcare politics all around the globe. And inside Cochrane, we have this early career professional, which is a global network that tries to give opportunities for those that are starting their research, their healthcare careers, and try to develop the leadership skills, try to create some educational resources, try and develop communication within their workplace, as well as develop methodology expertise. Our main objectives is to give early career professionals representation, diversity, and try and develop an international collaboration, as well as try for those that are starting their research program to develop some knowledge translation in terms of the research methodology for early students and those that are starting their PhD, doctorate, and everything else. If you are interested to try and follow us, there is a lot of links that you can try and email us as well with any questions that you have. By the start of this year, we had the opportunity for new early career professionals to join us. And usually we send notifications yearly by the end of the year for those that are interested to try to develop some project and participate in other projects such as this one. So you can find us in LinkedIn. We have our own Cochrane's main page, as well as some YouTube's playlists that we have for other online events. And as I previously mentioned, you can contact us via email. So for our lecture series, as I previously stated a lot of times, it's a pilot project. So the participation as well as feedback from you, it's really important for us so that we can try to conduct as best way, not only for next projects, but as well as for our next webinars, so that we can try and improve with each session what is best for you guys. Its main focus are undergraduate students. Sorry for the misspell here. So people that are starting their healthcare professionals, and with the main object to introduce them to evidence-based healthcare, how to interpret some types of articles, and how to utilize the main articles that we have in our daily practice as well. So with the main focus in types of studies and their methodologies. Just as a quick presentation, we have the coordinators. We have myself, Rin, who I think is present as well, and Magali, who I think won't be able to join. But I would like to thank both of them. Without them, this project could not have happened with all their help in their organization and trying to develop the best strategy. And as well, our presenters, you will meet Fabio soon, but we'll have all these great lectures with individuals that are in different areas of medicine as well as healthcare. So we have people in internal medicine. We have Rim, who's currently doing their formation in medicine as well. So we have a more undergraduate approach, and people that are in family and community medicine as well. So these are our next topics. Each month we try to update when it's going to be our next section, as well as what you can expect, so you can see if it's useful for you or not. So we'll start today with introduction, follow up with cross-sectional cohort, case control, RCTs, which is randomized controlled trials, systematic reviews, and we'll finish with Dr. Nordman with daily practice and guidelines. So I hope all of you enjoy. And I'll leave to Fabio if he wants to present himself. In the meantime, I'll try to prepare his presentation so that we can start.
Hello, everyone. Am I coming through okay? Okay. First of all, I would like to thank João and all the organizer for the invitation. It's a great pleasure to be here talking to you guys about a topic that I'm very passionate about, which is evidence-based healthcare and types of studies. And I hope that this lecture series helps everyone to improve and reflect upon what we're doing to deliver the best care that we can to our patients and to the society that we are in. So, I'm Fabio. I'm a family doctor here in Brazil. I met João when I was a resident and he was a medical student. And every day we talked about how important it is to study every evidence-based medicine and how often in our medical careers, in our careers as health professionals, we don't have many opportunities to discuss this kind of subjects. So when he had this idea of making this series of lectures, I was very glad to join and help as much as I can. So feel free to make any questions, comments in the chat. You can raise hands that we will try to answer the best we can. João, is the presentation ready?
Yeah, I'm just gonna send through email an attendance sheet so everyone can give their presence. So we will have one attendance sheet for the start of the series as well. By the end of the lecture, I'm gonna send another one with feedback forms as well. Okay, so it's really important, especially the last one for you, so that as I previously said, we can improve not only for next projects, but within our series as well. Let me just check if okay, it's gone. And then I'm going to start presentation. And Fabio, when you want me to pass on to the next slide, you can tell me. Just one moment.
Yeah, so let's get started. I think you can pass to the next slide, João. So, first of all, I would like to talk to you, invite you to think about why is this series important? Why are we doing so many webinars and lectures about different types of study? Why do so many different study designs exist? So first of all, I think we should take a step back. So you can pass to the next slide, João, and talk about evidence-based healthcare. You can press the next slide. There is a definition about evidence-based healthcare that is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. David Sackett was one of the fathers of evidence-based medicine, so he wrote a lot about this topic, and it's interesting how uh, it is needed. There is a need for him to define evidence-based healthcare because uh, it should be something that is natural for us. It should be something that we do every day. But he realized that it was not being done so often as it should. So he used this definition to try to spread the idea of evidence-based healthcare and how we should every day try to achieve this concept. So you can press you on next slide. When we talk about evidence-based healthcare, besides this definition that David Sackett used, there is three main points that we should never forget. First of all, we should always think about the best evidence that we can achieve, that we can find. And this is the main topic, it's the main pathway uh, to think about types of studies. Because if we want to find the best evidence, we need to know what each study is trying to tell us, what question each study responds, answers. So that this is the importance of we taking the time to think about every type of study, the bias that can arise from each methodology, how we can interpret the results in each study. So this is one of the main topics in evidence-based healthcare. But we cannot stop there. Once we once we find some study that seems uh, good, that seems to answer our question, we need to take the next step. We need to take it to the real world. So it's easy. Yes, you can pass to the next slide. We need this to take this information and apply this to a specific context and clinical expertise. So it doesn't work if some clinical trial, randomized clinical trial, says that the best evidence for a treatment about to some disease is a medication that I don't have in my country. So it's not applicable to my context. It doesn't work if it says that the best diagnostic test is something that my patient can afford, or I don't know how to interpret the results. So we always have to take the information that we get in the studies and the best evidence that we can find and apply this to our specific context and use our own clinical expertise. And last of all, of these three main points, we never we should never forget patient always comes first. So everything that we do, everything that we're trying to achieve, all this effort that we are putting on studying and trying to improve our practice is because of the patients that we take care of. It's because of the population. So we always have to take into consideration the patient values. So what is best for them, for each person. There is not one uh, universal rule that should be applied to every patient that we encounter. We always have to make some kind of shared decision making so we can adjust to the patient that we are currently treating. And when we are analyzing and appraising the studies and results that we get, we always should look for patient-centered outcomes because we can try to measure anything in the world, but we should take special care of the outcomes that really matter to the people. So it doesn't matter if we just if some study says that the medication improved some test result. We should we should ask one more question: is this helpful for the patient? What does it really mean in real life for the person that is taking the medication, that is trying to decide if they should go along with the tests or something like that? So these three main points about evidence-based healthcare is really, really, really important that we always try to uh, take take them all into consideration. It's very usual for us to focus on the types of study and best evidence, but we should always try to apply this to the real world. Next slide, please, João. So maybe you're thinking that it all makes sense. Of course, we should try to take this information, apply this to the real world, discuss with our patients. Isn't that how all healthcare should be? Maybe you're asking yourselves. So to discuss this question, I would like to present a clinical scenario so we can discuss this question. Uh, imagine this situation. A medical student is seeing a patient in an outpatient clinic when they evaluate a 9-month-old infant presenting with a viral bronchiolitis picture, rhinorrhea, cough, wheezing, and no signs of respiratory distress. He goes to his preceptor, to the medical assistant, and he presents the case. They describe the treatment options, they voice their uncertainty, the, but the preceptor doesn't even listen to them and quickly interrupts and says, just give them, just give the baby salbutamol. It always helps open up the chest. So imagine the situations. Maybe you already found yourselves in some scenario like this. Maybe you're a medical student and you always after you attend the patient, you have to take the case to the preceptor, and sometimes it can happen. So my question, uh, was this evidence-based? Was this behavior something that we can consider that was an evidence-based behavior? If you like to share your thoughts on the chat, feel free. Maybe you can pass to the next slide, João. And a second question after that. If you think this wasn't evidence-based, what is this based on? What was this based on? This clinical scenario or some situation that you found yourselves in? Feel free to write in the chat or raise your hands or talk in the microphone. I will continue with the presentation, but if someone's writes something, you can pause me, João, and share their opinion. So this clinical scenario wasn't really evidence-based. And to discuss this kind of situations, I would suggest you to look for this little clinical sketch, this short text that tries to make some parody about some behaviors that are not evidence-based and are something else. For example, there is eminence-based medicine. Try to think if you can imagine something like this. The oldest, maybe there's a clinic and there's an old doctor that is the most experienced, quotation marks, and what he says is the truth. No one can question their behavior, their opinion, and if he says to do something, it can be done. It should be done, and no one questions, and they go along with their opinion. This is not evidence based. This is eminence based, or other situation, eloquence based medicine. Nowadays it's very common in the social media that we see some really good looking people and health professionals with very clean Instagram pages, Facebook pages that talk about all kind of stuff, and they are really eloquent. They talk really well, and they present some videos with really cool edits and something like this. So impresses people, but it, we should look through this and try to see what is the information that the person is given, because many times it's not evidence based, it's eloquence based, it's something else. So this text tells about some other situations that you can after reflect upon and see if you can imagine something like this, or maybe someone who's doing this kind of behaviors. So it's really fun. I recommend you to read this text afterwards. So if the scenario that we saw is not evidence-based, what does it take to implement real evidence-based healthcare? This is a question that we should try to answer every day, because it's not as simple as one may think. Uh, Next slide, please. And I usually tell people who I am talking to this kind of subject that it all starts with curiosity. We are naturally very curious about the world around us, but sometimes during our professional careers, our student life, we lose a little bit of this. We start simply accept what the teacher says, what the preceptor says, and we often don't go after some of the answers that we might want to find. So I think that a very good message here it's it's to keep this curiosity alive, because every day you get next slide please, João. We have doubts and uncertainty every day in practice. Either either if you're a medical student, another health profession student, or you're already doing your clinic and you're already graduated or something like this, we all have questions every day. We all have insecurities. We all have doubts. So when we think about it, there are many things that we can go after the answers. Uh, Next slide, please. For example, I think everyone already had some doubts like this. Is a treatment with antibiotics going to help this patient? I'm not sure how I should proceed with this investigation. Should I prescribe a beta 2 agonist for this baby with bronchiolitis, like the clinical scenario that we just saw? So these are questions that we see almost every day, or almost every patient. We have some kind of question like this. So when we take a moment, we think about what we're doing, we can start to realize that we all are curious about these kind of things, and we can go after these answers. Next slide, please. So a next step after we realize that we have doubts, we have questions, we are curious, is try to formulate some kind of more specific question. Try to find a method that helps us to understand what we're looking for. So there are many aspects of question formulation that are important to talk about. One of them is try to differentiate the background questions to the foreground questions that we see every day. Next slide, please. So a background question, next slide, is a more broad, general knowledge about basic concepts. Next, please. Some text says that we usually, when we're talking about background questions, we use these words like who, what, when, where, and why. Next, for example, what are main clinical features of viral bronchiolitis? This is a very background question. Maybe you are starting your studies about this topic, and you want to have a more introductory study about this. You never saw a real patient with a clinical features of viral bronchiolitis, so you have to have these kind of questions and try to answer them. Or another example, how does diabetes affect the kidneys? It's a very physiopathological questions that maybe we see in the first years of the medical school, or we try to find some answers in textbooks or something like this. So some of the questions that we see that we have in our daily lives are background questions. Next, please. These kind of questions are really well answered in some kinds of material resources like textbooks, review articles, practice guidelines. So usually we will find some uh, introduction about this topic in the chapter, the textbooks about diabetes. Or we when we search for review articles, the author will usually try to make some context and introduce some background information so we can understand. So when we realize that we have a background question, these are very good sources that we can try to find to answer our questions. Is a little different from foreground questions. Yeah, next slide, please. Next. foreground questions are more focused questions addressing particular aspects of clinical practice. And usually it's best if we use some kind of framework or some methodology to try to help us to formulate the best question possible. For example, I don't know if you ever heard of PICO, but PICO is a very famous framework for us to try to formulate foreground questions. Next slide, please. So PICO is it stands for Population, Intervention, Comparator, and Outcomes. So it's very useful for us to trying to uh, understand what we're looking for in this kind of questions. Next slide, please. So in this situation, in this example that we're discussing, a PICO question could be, for example, infants with bronchiolitis should be the population. The intervention could be use of beta-2 agonists, for example, salbutamol or albuterol. The comparison could be supportive care without a beta-2 agonist, for example, a placebo or a no use of bronchodilator. And the outcomes that we are trying to understand if it changes something is the improvements in clinically important outcomes. For example, reduced hospitalization, improved oxygen saturation, reduced symptoms, severity, duration. So when we take this curiosity, this uncertainty, and we try to put in the PICO question, we usually find that it makes easier for us to understand what we are looking for. So there are many frameworks like this. PICO is just one example that is really useful for RCTs, clinical trials. But for example, PECO, that it's the second on the list, is very useful to exposures. So cohort studies, for example. PERT is very used to diagnostic tests. So we can start to uh, get usual get familiarized with this kind of frameworks so they can help us to try to formulate the best questions. Next slide, please. And maybe this is the main point of this whole talk that we're doing here, this whole lecture about introduction about types of study. Each question has its study. So this is why it's so important for us to try to make the best question possible. Once we have the best question that we can possibly can, usually it makes easier for us to understand what study, what type of study we are looking for. For example, if we know that we're trying to understand something about therapy or some kind of medical intervention. Maybe one example of a very good foreground question can be, in adults with stage 1 hypertension, does starting a low dose thiazide compared with lifestyle modification alone reduce cardiovascular events? So this is a very good, very structured search question. Then we know that maybe the best study design to answer this is a RCT, a randomized clinical trial. But if we realize that no, our question is different. It's about risk factors. So we try to think about how we can formulate this question, and we come up with, in adults, does long-term cigarette smoking increase the risk of lung cancer compared with never smoking? So this is a different question. We can, after that, we can start searching for other types of study design, maybe a cohort study or a case control study, which is more suitable to answer these kind of questions. So this message, this point of each question has a study is very, very important. And in the process of the series, in the next lectures, we're gonna go through um, specific details of each study design, how we can interpret them, what are the limitations of each design. So we're looking for these next lectures that are going to be great. And just a reminder, we can do a standalone study, like we do one simple study, and we can do reviews. Maybe there are many trials that try to answer the same question. We can then search all of them and make a review. And we have many kinds of reviews. There's a complex classification. Different people call them different things, but in general, we can talk about systematic reviews with meta-analysis, which is more rigid process. We need to include our criteria of including each study, our exclusion criteria. We need to have some kind of method of assessing the quality of the studies. There is more relaxed kind of reviews, like uh, narrative reviews or scope reviews. They are all useful, but we need to understand what are the main objectives and limitations of each one. But this message, each question has its study, should stick in our minds. Next slide, please. So once we know what is our question, what study should be the best uh, choice to try to answer this question, we can start our journey to search and retrieve this best evidence possible, these studies that we are trying to look for. So there are many ways we can do that, but usually we recommend to use some kind of database that is appropriate for this task. One of the most famous database in the world is PubMed. So you can pass to the next slide and can click again, please. So PubMed is a very large database, the largest in the world. So anyone who publishes a study tries to index to this famous database. So afterwards, people can find the study that we just did. So we usually go for some kind of tool like this, a search tool in a large database, and we can try to use the best search strategy. And once we get used to this, it's less scary. But I know that at first sight, it can be really complex. So we usually see these terms like mesh terms and these operators like and, or, and publication type, and we can get a little overwhelmed by all this information. But actually, when we try to understand these strategies, we see that it's not all that complex. Next slide, please. All we are doing is taking the information that we thought about in our question formulation and trying to uh, translate it to the best way we can use in the search strategy in the database that we're using. So each database has some kind of specificity or some trick that we can use. But the main message is that we are trying to take that PICO question and put in the search strategy. So we're trying to put in on the population, the intervention, the study design. Next slide, please. Usually, we don't add the comparator or the outcomes in the search strategy. We need to look for them in the abstract, in the methodology of the text. So usually after we put some search strategy like this and click enter, the result will return with hundreds of studies. So we can browse the studies and try to find the one that best answers our questions. Once we start to read the study, the whole study, we can search for the comparator and the outcomes to see if it's well suited with what we're looking for. Next slide, please. And let's think about the clinical scenario that we just saw. Baby with bronchiolitis and salbutamol or beta 2 agonist. If we do some structured search strategy and we look in PubMed the results, we are going to find some really interesting studies. One of them is this systematic review that was published by Cochrane, which is very well done. Was published in 2014, and kind of answers really well what we're looking for. So we can see the objectives to assess the effects of bronchodilators on clinical outcomes in infants with acute bronchiolitis, which is just the clinical scenario that we were in. The selection criteria: randomized controlled trials comparing bronchodilators with placebo or placebo bronchiolitis. So even the comparator is very suitable with what we're looking for. Next slide, please. When we go through the study, we can see the author's conclusion. It's very interesting. Bronchodilators such as albuterol or salbutamol do not improve oxygen saturation, do not reduce hospital admission after outpatient treatment, do not shorten the duration of hospitalization, and do not reduce the time to resolution of illness at home. So when we read this study and we think about what the preceptor said to the students, we can see that is not really what was recommended by the medical assistant, by the clinical preceptor. And it usually brings some kind of, I don't know, feeling that why? Why he said that that I should give the baby, the patient salbutamol if it does not improve the outcomes that we are looking for. So we can then critically think about the 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 healthcare that is being done in our context. So once we get we get used to doing this, it should never stop. When we realize that many things that is passed on uh, colleagues and preceptor is not evidence based, we need to make this routine of always checking what is the best evidence available and what is being taught, and to see if there's some kind of discompass or some difference in what is being taught and what the evidence says. So this process of curiosity, question formulation, uh, search strategy, and retrieving the best studies is much valuable for our daily lives. Next slide, please. Of course, that we shouldn't just believe what every study says, just because the conclusion of the author says that the beta 2 agonist is not good. Okay, so I believe them. No questions asked. No, we should always try to critically appraise each study that we encounter. And this is not the scope of this lecture, but there are many steps that we can take to see if a study was conducted well or if it's not a good study. For example, uh, we can ask ourselves, are the results of the study valid? So we can check internal and external validity. We can check if the study design was the right choice to the question that was being made. We can assess the risk of bias in each study, in each type of study. We can try to think about the quality of the measurements. Next slide, please. We can think about and then analyze the results themselves. For example, the effect size, if the measurements, the effects were absolute or relative, the precision of the measurements, the statistical significance, the consistency of the findings. Next slide, please. And we can always try, we should always try to take this next step. So, okay, even if the results are valid, the results are, the effects are good, I think the study was well conducted, we should always ask this question: will they help me care for my patients? So we try to think about the clinical relevance, the feasibility, the benefits and the harms about that intervention or what we're studying, the cost and the resources, trying to take the information and apply them to our context. Next slide, please. And there are many resources that help us do this. When we first start to try to read whole studies, is not an easy task. There are many words, vocabulary that we are not very used to. There are some statistical concepts that maybe we weren't introduced to in school. So when we are in the beginning of the journey to try to be evidence based, it's very useful to take some kinds of take some resources, maybe some books, maybe some checklists, maybe some methods that can guide us to this process of appraisal. I put on this slide some that I really like. For example, this book, User's Guide to the Medical Literature, that is by JAMA, is very, very nice because it presents some questions that we should make in every type of study design. So it helps us to think about these kind of points. There are some other resources like this Critical Appraisal Skills Program, CASP, which has some checklists that we can use to try to answer these questions that help us to answer if it's a good study or not. And Cochrane, of course, that is very specialized in systematic reviews and stuff like that, has many handbooks and some tools that help us to think about the quality of the studies and risk of bias. So it's very recommended for us to take this kind of guides to use when we're first starting to critically appraise the studies that we encounter. And of course, even if we find some good evidence, a really well conducted study, results that are very valid, we always try to translate this to our specific scenario, our context. So this is what I'm calling here clinical translation. And also, there are many steps for us to do this well. Next slide, please. For example, risk communication. When we are trying to explain the results to a patient, it's a very hard task for us to explain. So if we take this medication, the risk of you to have a complication in the future in the next 10 years goes from 20% to 15%. So uh, is is the patient really understanding what we're trying to say? So when we try to get better at risk communication, the patient can take a lot of benefit from it because he then can take a more conscious decision about whether he wants to take the medication or not. Next slide, please. So this involves something that we call shared decision making. When we take the evidence that we have in our hands, the information that we have, and translate this to the patient, so it can together try to find what suits best for the patient values and preference. And we always try to check his understanding if it's good for him, if it's not good for him. Next slide, please. And we can implement this kind of interventions and the information that we find, and we always have to reflect if it went well, if it didn't went well. We can monitor the results and reassess our process. Next slide, please. So one of the last key points that I want to bring here is the evidence-based healthcare is a cycle. It never ends. So we start with a clinical question. We are curious about finding some answers about something that happens to us in our practice, and we try to acquire the best evidence. We appraise the evidence to see if it's a good evidence or not, if it's a good study or not. We then apply the evidence to patient care, to real patients, and then we assess the results. This is what we call the 5 A's of evidence-based healthcare, and it's a very nice cycle because it never ends. After we answer one question, we can go to another. We can always try to improve what we're doing. We can take the evidence that we thought it was going to work with that patient, but it didn't, so we can try another thing that we find. So it's a very beautiful process, the cycle of evidence-based healthcare. Next slide. So to finish our lecture here, the main takeaways that I would like to reflect upon. Unfortunately, not all healthcare is evidence-based, but it should be. Evidence-based healthcare is about better decisions for real people, so we cannot stop at the study, the results. We should take these results and apply them to our context, to our clinical expertise, to the values and preference of each patient. So this step is very important. Each question has its study, and evidence-based healthcare is a continual process. Remember the 5 A's. The next slide, please. And remember, it all starts with curiosity. Please never lose your curiosity. Always keep up making questions, trying to find the best answers that you can for your question. Discuss this with your colleagues, with your professors, with your preceptors, because this process, this never-ending process, is what makes us improve as health professionals, as clinical doctors, as students. So it all starts with curiosity, and please keep up with the curiosity. So these are some references that I used to make this lecture. So I hope that it was helpful for you guys. And if we have any questions, we can discuss them now.
Thank you very much for the presentation, Fabio. Let me just check to see. Sorry, there's a church close to my to my house, so that's the noise. Let me just check to see if there is any questions here in the chat, but I believe someone raised their hand, and I'll try to let me just check who raised their hand. Oh, no. Oh, I think it was just mistaken. Please, if you have any questions, feel free to leave in the chat as well. If you'd like to ask in front of Fabio as well, I can free your video and your microphone. I'll just take this time to share our attendance and feedback form as well, so that you can have your attendance. And Ring has a question. So what would be your opinion on evidence-based medicine in countries with limited resources and knowledge on research?
That's a very nice question. I think that as we discussed, evidence-based medicine is not one task, one isolated task. It involves uh, so many things, since the research itself, So maybe that's what you're asking, if there's no maybe money, infrastructure to do some good research. But it involves also the process of the question formulation, the search strategy, and we trying to apply the best evidence that we can. Maybe if it's not perfect for our context, maybe it was maybe some research that was done in Europe, and I am here in Brazil. So can I use this information to apply them to my country? This kind of critical thought is evidence based. This is essential for us to try to answer. So maybe if it's not perfect, there are some information that we can use and we can apply safely to our context. Maybe there are some that it's not possible to do that. So when we start to study this whole process, we see that it does not end in the research itself. Everything else that comes after also is involved in evidence-based practice. But I know there are many places with limited resources that is very hard for us to conduct some types of research. So I know what you're talking about. Even in Brazil, it's very different from place to place. There are some regions that are very rich and very full of resources, and some regions that are very limited in terms of research and infrastructure. If you have some insights about this, I would like to hear from you also, Rim, because it was a very nice question.
Okay, I think we don't have any more questions. Fabio, I would like to thank you very much for the presentation. It was lovely and really inspiring as well. Uh, oh, I think Rin answered as well. Oh,
So I'm currently based in Cyprus, so most of the evidence-based medicine is based on European guidelines. Yeah, I know what you're talking about. Even here in Brazil, some areas we don't have specific guidelines and research for our population. So we need to try to translate the evidence that is being made, that is the research that's been done in other countries to our specific context, and it's very challenging. What do you think about it, João, about this
I
topic?
I agree with you, Fabio. I believe, at least in the hospital, one of our main difficulties is trying to translate the best evidence that we have and that we try to follow from different countries into our practice. So there are a lot of situations that we have sometimes we have the access to the best pill or the best treatment, but we have some gaps, some period that we have gaps so that the patient can have access for this medication as well. So then we also try to weigh in what are the benefits to try and do like intermittent treatment, since
Yes.
the patient will not be able to take the pill or try to come to the pharmacy and try to take the medication to have like IV infusions, so they live around 3 to 4 hours from the hospital. So I totally agree with you that the best evidence-based healthcare that we can do always starts with the patient and their scenario. So we need to try always guide with this situation. And
And
also something that we always discuss at least in our lectures is that it's difficult for us in Brazil as well to have representation in terms of the population. So since most of the studies are based in the North Hemisphere and most of the like USA and Europe, the majority of the population is white.
yeah,
And here in Brazil, we have a majority of population that is black or with less people that are white as well. So not always we can apply the best evidence that is applied to the US and Europe here in Brazil. We always need to address that as well.
Yeah, I totally agree. We should fight for a more racial uh, equity research. So it's a very hot topic. Everyone is talking about this, fortunately, because it's very important. And one point, just to add to what you're talking about, is that we should always take the culture of the place into consideration. Sometimes in some country, it's very common to do some kind of habit or it's okay to take one kind of pill or to go through some exam. And in other countries, it may be strange. It's not very usual. So even culturally, it's very challenging to adapt some of the recommendations that are done in some other guidelines and something like that to our specific context.
Exactly. I think we have another question. So Evelyn has asked us, how do you make shared decision making with patients who have little knowledge? Like here in Brazil, where a lot of people know so little about health and how the body works.
That's a very nice question, Evelyn. Uh, there is an area of research that is called health literacy, and there are many studies being made of how we can best try to translate this complex topics that sometimes even we as students, doctors, have trouble understanding and translate this to the general population. And it's very, very, very hard. But there are some general rules like plain language that we can adapt our vocabulary and try to use shorter phrases to explain some concept to people. We can always use some communication techniques. There is one that is called chunk and check. We deliver some parts of information, and then we check the understanding back, the what the patient understood. Then we go a little further and try to expose to some new information, and then we take the information back. So this there are some things that are helpful. Also, now there are many visual tools that try to help people understand what is being said. So when we talk about statins and cardiovascular risk, there's some visual aids tools that have this happy faces and sad faces to show how many people have the benefit when they take the pill, for example. This is challenging, but when we try to put some effort into it, we gain some insights, and we start to improve our communication, our risk communication and health literacy of the population.
Also, just trying to compliment you as well, Fabio. It's not only trying to explain the information that you're trying to address, but it also helps the patient maintain its adherence to treatment and
Yeah.
to raise another questions, not only from the patient, but from their family. So it's like a little seed they can implement when you're trying to influence the medical literacy and trying to address all of the questions, and they could try and pass it on with their families, with their friends, and also develop like an horizontal field and communication within the patient and the population that are trying to target as well. I think Evelyn has another question, so I'm just gonna leave it a few more minutes so that we can try to answer it as well. If anyone has other questions as well, and feel free. And if you'd like to speak freely as well, just let me know so that I can free the mic and the camera.
Yeah, but Evelyn's question was very, very nice, and I think that a good suggestion for any health professional is to try to get better at communication. And one thing is that it's not a natural thing that maybe whether you have it or don't, you can improve this. It's some skills. It's a set of skills like any other. Like if you train many times a procedure, you get better at it. If you train and study communication skills, you also can improve. So there are many books about it. There are articles and research about communication and how we can best do it to our patients.
So I think Evelyn said that all her questions were answered. I'd like to thank the presence of each and every one of you. Please do not forget to answer our feedback form so that we can improve for our lectures and next project. Fabio, again, thank you very much for the presentation.
It's my
If it's
pleasure.
okay to you, maybe we could share via link later on via email the presentation so that people can take a look as well.
Sure, sure, no
Okay.
problem.
Okay, thank you very much. I'm gonna finish the event so far, but you can also, if you need to review something that was said, uh, soon the recording will be shared via the Cochrane's YouTube platform as well, so you can check and you can share with your friends. I'd just like to point out if you did like the series and if you're thinking the webinars are helping, please share with all your friends. We have the registration form that is still open, and we'll try to keep the communication via email so that everyone can be up to date with our next webinars as well. If you'd like to make any final regards as well, feel free, Fabio.
Oh, it was a great pleasure to be here with you today. It always uh, inspires me to talk about evidence-based healthcare with so many interested people, and we can share our different experiences. And it motivates me to study more and be more curious. So I would really like to thank you, João, and for the Cochrane organization for the invitation. And feel free to contact me if you have any questions, if you wanna talk about more about the subjects. I always very passionate about this, very enthusiastic about this kind of subject. So I'm always down for some good conversation about evidence-based healthcare.
Great. Thank you, everyone. I'm gonna finish the session right now. Thank you, Fabio, again.
Thank you, everyone.